Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. In this very special episode of 1 p.m. today, we have Dr. Will Courtney to take us through exactly how you'd approach atrial fibrillation in an OSCE situation. Thanks, Will.
Thanks very much for having me on the program. So what I thought we would discuss today would be atrial fibrillation, mainly because atrial fibrillation is one of those extremely high bang per buck topics that all medical students should know. It's one of probably, you could say, the top 10 subjects. It's coming up most of the time. So without further ado, let's crack into it. So how do we diagnose atrial fibrillation? Dan, to you.
I would say based on an ECG.
That's right, yeah. And what are you looking for on that ECG?
A lack of P waves and just little bumps.
Fibrillations.
Yeah, fibrillations.
Yeah, good. And what else? Jason, your turn.
The most important aspect, a thorough history of atrial fibrillation.
You're not wrong. However,
I didn't just rush to the investigation.
You're dead right, actually. So Jason, you've been called to a sick patient, and you've done your ABCs, you've taken your history, and you've done your exam, and you've been shown an ECG. What on that ECG identifies atrial fibrillation?
Sometimes absent P waves.
Yes, that's one of the two criteria.
And you see not like a flutter. I don't know how to describe it, but
you can see a fluttering.
Like a ziggy-zag.
That's not one of the diagnostic criteria, though. So the two things that you're looking for are lack of P waves, and I know JT knows, but it's irregularly irregular.
Oh, okay. I was guessing, but
yeah. So it's
cool.
an irregularly irregular rhythm. Okay.
Right.
So these are the two things that you need to know. If you don't know that, you need to know it now.
So
all right.
Can you just clarify what a irregular rhythm is?
Yeah. So it means that there's no pattern to the rhythm whatsoever. There's just a QRS, and there might be a second, another QRS complex. Might be 5 seconds and another QRS complex. There's no discernible pattern. And that's what happens in atrial fibrillation, okay?
And a question, the only diagnosis of irregular is not just AF, right? There are other ones.
The other diagnosis that springs to mind is atrial flutter with variable block. So atrial flutter is slightly different to atrial fibrillation in that there is a circuit being built around the atria that runs at approximately 300 times per minute, and however many times that conducts. So if it conducts at a 1-to-1 rate, your ventricular rate is going to be 300, which would kill you.
Right.
But generally, that's not what happens. In A flutter, your rate is generally 1-to-2, which means that would be running at a rate of 150, but it could be 1-to-3, it could be 1-to-4. And so if there's a variable rate of conduction, that would mean that the A flutter is conducting at 1-to-2, one beat, 1-to-4, the next few beats. So that would also be irregularly irregular, but you will see P waves and you'll see a sawtooth pattern. And that's what's going to delineate a flutter from atrial fibrillation. Okay, so in atrial fibrillation, it's irregularly irregular and there are no P waves. Okay? And the next thing then, Adian, what happens to you? You stumble across a patient, you've done your assessment, your physical exam, they look like they're stable, they are having palpitations, you've seen the ECG with atrial fibrillation, they are having atrial fibrillation with fast ventricular response. What are you going to do?
So they're stable.
They're stable, you've done your ABCs.
Okay, so then
you're honing in specifically on the management of atrial fibrillation.
I think I would consider if I want to do rate control or rhythm control.
Okay, so good suggestion. What I do is it's solid. I have a method for dealing with atrial fibrillation when I come up against them, and it's kind of an all-encompassing method to make sure you don't miss anything. What you're talking about, rate and rhythm control, is an extremely important part of it. However, the first thing that I do when I use a mnemonic CAR, C-A-R, okay? And I use this mnemonic just because you can talk about rate and rhythm all day, and next thing you run out of time in your OSCE. You haven't discussed the causes, and you haven't discussed anticoagulation. Two other factors of AFib management that need to be hammered out and are very quick. So if you can get 1/3 of the marks for treating the cause, 1/3 of the marks for anticoagulating, and then you can focus on the last 1/3 where you're focusing on rate and rhythm control.
Okay.
Okay. So JT, what are the main causes of atrial fibrillation?
The main causes, I guess, would be the contractility of the of the heart? Is
Impaired contractility in heart failure could cause it. But really what we are looking for here is the 3 top causes of atrial fibrillation would be valvular heart disease, ischemic heart disease, and thyrotoxicosis. So when you're asked the causes of atrial fibrillation, say those 3, say them fast, say them up front, okay? And then another 3 for you to learn that are less important but still important: electrolyte disturbance, infection, and post-op. Okay, if you can just blurt out those 6 causes, you're fine. So use a little mnemonic, do whatever you can. There are many causes. They would be identified, what I've just said, are causes of atrial fibrillation. But then there are other things which we'd kind of say they're substrates. They contribute to you getting atrial fibrillation, like age, BMI, obstructive sleep apnea. They don't cause it per se, but they put you at risk for it. Yeah. Okay? But I think when you're asked in an OSCE what causes atrial fibrillation, really what they want to hear is valvular heart disease, ischemic heart disease, and thyrotoxicosis. But once you've said those 3, you've said the bulk. And then you go into electrolyte disturbance, post-operative, and infective. There are 3 other good causes, all right? Now you can move on from cause. They're going to be pretty happy with that. You clearly know your stuff. You've said the cause. They're going to let you drive the car from now on, okay? So
I'm just going to interrupt.
Yeah.
So what was the etiology with thyrotoxicosis, and how does that then lead to AF?
So thyrotoxicosis basically causes a syndrome of effects, and one of them will be tachycardia, and tachyarrhythmia and atrial fibrillation.
Yeah.
Suffice to say, if you're in an AFib station, they'll probably just want you to say thyrotoxicosis, and then you can say, we can do this medically or surgically. However, before I start talking about thyrotoxicosis, I would like to anticoagulate the patient. So you drag them back into atrial fibrillation, all right? Yeah. And medical OSCEs are very like that. If you know where you're going with your next statement, you can guide the examiner rather than allowing them to guide you.
It's like a game.
Yeah, a little bit.
Yeah, like a performance.
But if you see atrial fibrillation and you're thinking CAOR, no matter what, I'm getting through CAOR by the end of this. You've said the cause, they're trying to bring you somewhere else, but you're getting to anticoagulation because you've left half the marks behind.
I'm glad it's another mnemonic other than another ABC, because I feel like there are at least like 5 different other ABC.
Yeah, that's right. Yeah. And then you have to come up with your own mnemonics as well, Yeah. So the next thing would be anticoagulation, all right? So Dan, would you anticoagulate everybody in atrial fibrillation?
I don't like blanket statements.
Good.
I don't like
Good start. Good start. Good start. Yeah.
They might already be on anticoagulation.
Yeah, good.
They might have von Willebrand's disease or some coagulopathy.
Okay. You are walking yourself down a hole there, because the next thing is what's von Willebrand's disease, and you've got dragged away from atrial fibrillation.
Okay.
All right. So what I wanted you to say there was CHADS2 VASC score.
Okay.
That's what I wanted you to say. Do you know what the CHADS2 VASC score is?
Oh yeah. Okay.
Congestive heart failure?
Yes, correct. Yeah. Everybody can help out. Yeah. Hypertension.
So H for hypertension.
Yeah.
A for
age.
There's 2 ages though.
That's right.
Yeah.
So,
but this A is 2 marks, I think.
No, this A is 1 mark, and it's for 65 years of age.
Okay.
And so that's CH, and they're all getting 1 mark each up to this point. So congestive heart failure, 1 mark. Hypertension, 1 mark. Age over 65, 1 mark. Diabetes,
D.
1 mark.
Yeah.
What's the S?
V for vascular disease.
Before that, S.
Oh no, sorry.
Stroke.
Stroke or
History,
TIA. That's getting 2 marks.
CHAD-S,
okay. CHADS 2. VASC. V is
vascular disease.
Peripheral vascular disease. That's getting 1 mark.
This is age 75.
And over. Yeah, that's right. And that's getting
2 marks.
Yeah. And what's the S getting?
It's 1 mark.
And what is it?
Sex.
Yeah. Exactly right.
And it's female, right?
That's right.
Yeah.
So if your CHADS2 VASC is 0, would you anticoagulate?
No.
Not indicated. Yeah, it's not indicated. Some people do, but the answer in an OSCE is no, it is not indicated. If their CHADS2 VASC is 1, you would probably anticoagulate. If it's 2, you would anticoagulate.
So if you're just female, you just
automatically
anticoagulate.
So now that you've asked, I wasn't. So you only get 1 mark for the female bit if you got a mark somewhere else along the way.
Right. Okay.
Oh.
Yeah.
Oh.
Because otherwise you would anticoagulate.
So a 30-year-old female.
I don't need to know that. That's too confusing.
Yeah. Well, just suffice to say that a 30-year-old female has a CHADS2 VASC of 0.
Okay.
if she doesn't have hypertension
Yeah.
or peripheral vascular disease or diabetes.
That makes a lot more sense.
Yeah. So anticoagulate. Would you anticoagulate everybody? I'd calculate their TADS2 score, and if it was 1 or more, I would anticoagulate them full stop. They're not going to ask any more than that. Now, what are you going to anticoagulate them with?
I think first line is apixaban.
Okay. Jason, what's the dose of apixaban?
I have no idea.
Okay. 5 milligrams BD. All right? So 5 milligrams twice a day. It's an oral dosing.
Yeah.
Unless they qualify for the 60, 80, 133 rule. Okay? If they are less than 60 kilos, over 80 years of age, or their creatinine is 133 or more, they have 2 out of 3 of those criteria, you only give them 2.5 milligrams of apixaban. Okay? It's the only caveat in the use of apixaban. All right? It's the 60, 80, 133 rule. All right? There's lots of different rules for lots of different anticoagulants, but I actually think apixaban is one worth knowing. It's the most common one. You'll need to know it not just for atrial fibrillation, you'll need to know it for venous thromboembolism.
And they follow the same rule?
They follow the same rule.
Okay.
You decrease the dose of apixaban if you have 2 out of those 3 criteria. Okay? Now, JT, would you ever not use apixaban in anticoagulating somebody for atrial fibrillation, even though their TADS2 score was high?
I believe there are other drugs out there.
Yeah. Any others? Name a couple.
I don't know if that
Enoxaparin, yeah. So subcutaneous enoxaparin is a heparin-based drug, and that can be given. But really what I'm looking for you to say is warfarin, okay? And warfarin is used instead of apixaban mainly in 2 instances. If the patient has a metallic heart valve or if they have valvular atrial fibrillation. So if their atrial fibrillation was caused by moderate or severe mitral stenosis, that's called valvular atrial fibrillation. And in that instance, you would anticoagulate them with warfarin. Okay? And so now you've done C, you've done A, and now you can move to OR, which is more complicated. Okay? So rate or rhythm control, which do you pick? JT, do you have a reason for picking rate over rhythm control or rhythm over rate control?
I'm not sure. How would you even derive
It depends
that?
on the kind of atrial fibrillation, and this brings us to a new definition. Okay? If you formed atrial fibrillation, in the last couple of days, and the atrial fibrillation lasts for less than 7 days, that's called paroxysmal atrial fibrillation. If the atrial fibrillation lasts more than 7 days, it's persistent atrial fibrillation. Okay? If the patient has long-standing atrial fibrillation and you don't want to do anything about it, you're just going to rate control them, that's called permanent atrial fibrillation. The difference between persistent and permanent atrial fibrillation is your intention to treat. If you have a little old lady and she's been in long-standing atrial fibrillation, she failed her antiarrhythmic therapy, she had multiple ablations, she failed those ablations, and now you're just saying, we're just leaving her in atrial fibrillation, we're putting her on some beta blocker. That means she has permanent atrial fibrillation because you no longer intend to get her back into normal sinus rhythm. If you have another little old lady and she's getting really short of breath with her atrial fibrillation, and you want to get her out of the atrial fibrillation back into normal sinus rhythm, you don't call that permanent atrial fibrillation because your intention is to treat it. You then call it persistent atrial fibrillation.
So why wouldn't you want to treat the rhythm?
We'll come to that.
Okay.
But permanent atrial fibrillation is persistent atrial fibrillation that you've chosen not to treat with antiarrhythmic therapy. So why would you do that, all right? There's a couple of reasons. If a patient is very young, you don't want them to be in atrial fibrillation, so you will rhythm control them straight away because it's better heart function for them. The prognosis is better if they're in normal sinus rhythm. Okay, that's number one. Number two, even if it's an older person, but they're really short of breath with their atrial fibrillation, you'll say, look, we actually should rhythm control them now because their quality of life is being dramatically affected. However, some older people particularly have so many risk factors that predispose them to atrial fibrillation, valvular heart disease, ischemic heart disease, they're elderly, they could be obese, that each time you rhythm control them, they end up going back into atrial fibrillation. And so they end up having a really turbulent time, in and out of hospital all the time, tried on new drugs, having the side effects of amiodarone and other drugs like that. And then eventually you just say, on balance, for you, it's better just to rate control your atrial fibrillation.
So it's not worth the side effects of the...
It's not everything. It's not, first of all, rhythm control is failing.
Yeah.
And second of all, it's not worth the side effects.
Okay.
Okay?
Yeah.
And in that person with permanent atrial fibrillation,
Yeah.
and for the sake of your OSCE, you would just say if the patient is in permanent atrial fibrillation, there are 3 agents that you can use: beta blocker, calcium channel blocker, or digoxin. Okay? So you can see that OR can be quite complicated when you go into it, but it doesn't have to be complicated. When you arrive at OR, the first thing you say is, you might rate control the patient. The reason you would rate control the patient is if they are in permanent atrial fibrillation and the goal is no longer rhythm control. Yeah. In this instance, I would give them a beta blocker, perhaps a calcium channel blocker, or digoxin. Move on. Yeah. There are a certain cohort of patients that I would rhythm control, in particular, young people. The way I would do this is I would calculate the CHADS-2 VASC score, and if it was 1 or greater, I would anticoagulate the patient for 3 weeks before bringing them back and doing a cardioversion, either chemically or electrically. Okay. That's kind of the end of the discussion in the OSCE, because they won't really get to ask you too many more questions because you've covered everything so comprehensively there. There are a few things that they could say to you, though. Would you always put them on 3 weeks of anticoagulation? There are 2 reasons you wouldn't.
Has bled?
Exactly.
Yeah.
There are 3 reasons you wouldn't.
Yeah.
So there are 3 reasons you wouldn't. If the has bled was really high, you wouldn't put them on anticoagulation. But the other reason is if their CHADS-2 VASC was 0, you wouldn't put them on anticoagulation. And the other reason was if their atrial fibrillation had been ongoing for less than 48 hours. In that instance, it's deemed safe to cardiovert them immediately.
Is that what you call a paroxysmal AF? Is that because earlier you said it was less than 7 days, right?
Yeah, it's paroxysmal atrial fibrillation because it's less than 7 days. But the thing about paroxysmal atrial fibrillation is, and the definition of paroxysmal atrial fibrillation is, it lasted less than 7 days before it reverted itself. If you had to do something to revert it, like give drugs or give a shock, then it is by definition persistent. Okay?
God, these definitions.
Yeah.
Even if it's reverted.
Yeah, but it persisted until medical therapy was given.
Right.
Whereas paroxysmal is purely a short, transient burst of atrial fibrillation.
So it spontaneously resolved.
It's self-terminated.
So you can only really call something paroxysmal after the fact, after it's reverted, and you know that they've had it for less than 7 days.
Correct. And the most likely people who will get paroxysmal atrial fibrillation are the second 3 causes that I was speaking to you about. The post-op patients, the electrolyte disturbances and the infections.
Who are otherwise healthy.
They're otherwise healthy. They just went into atrial fibrillation when they had a pneumonia in hospital. Post-cardiothoracic surgery, a third of the patients get atrial fibrillation. And in those patients, because it is expected, because everybody identifies it at the time as this is probably paroxysmal atrial fibrillation, the decision is often made in those patients, particularly if their CHADS-2 VASC is 0 or 1, to not anticoagulate.
Just to let it run its course.
And you would just monitor daily.
You would monitor
ECG and
daily ECGs, and you'd make sure. And if it reverted, you might then subsequently say, in a note, you might say, I believe this, and it would be a senior doctor in the team who would do this, I believe this is paroxysmal atrial fibrillation in the setting of whatever insult they had be it surgery, infection, electrolyte disturbance, and the atrial fibrillation resolved. I would write to the GP and say, can you please check this in a few weeks' time? If they are found to be an atrial fibrillation again, we will at that point need to anticoagulate because it's clearly not paroxysmal at that point. Yeah.
Is that ever a significant medical history? If I were to see a patient like 70-year-old and then in their 30s, you wouldn't write it down anywhere,
if it was deemed to be paroxysmal and they reverted out of it,
then it's just non-significant.
No. The answer to that in a question, though, would be all medical history is relevant. If they were recorded in atrial fibrillation at one point in the past, then I would, of course, document that. So it takes nuance and an experienced physician to say, we won't document that because it might cause a cascade of non-beneficial things to happen to this patient. That's complicated and it's not coming up in your medical.
It's like a penicillin allergy.
A little bit. Exactly right, So for the people listening to this podcast, if somebody has atrial fibrillation, you document it and you anticoagulate them.
Yes.
All right. So that's quite important.
In general, though, would you say persistent is much more common than paroxysmal, or is it? Is that not really
No,
important?
paroxysmal is probably more common, but the
Okay.
thing about paroxysmal is you don't catch it because it's happening to healthy people, and it's of no significance anyway because
That makes
those
sense.
people aren't, they're not. It's not manifesting as a cerebrovascular event. So I think to come back and focus on the high bang for buck stuff, because we covered quite a bit there. The things that you will need to know are, firstly, how to diagnose atrial fibrillation. No P waves, irregular QRS complexes. Okay? Now, once you know you have atrial fibrillation, the examiner will say, what would you like to do? The first thing you're going to do is...
A through E assessment.
Yes.
Yeah.
It's always right. It's always right. Yeah, it's always right. A through E assessment, you make sure they're stable. Yeah.
A through assessment, history, all of that, and ECG.
Yes, and now you've seen the ECG, and each time, don't let somebody catch you out. It's always the right thing to say, A to E. If you haven't said it at the beginning, then you need to come
It's
back
like writing
and
your
say...
name on the test.
It is. Because if you jump in and look at the ECG and you haven't looked at the patient, you're not going very far. So that's correct. A to E, you've looked at the ECG. The ECG showed you...
irregular QRS complexes and absent
Say
P waves.
irregularly.
Oh, irregular.
No, say irregularly, irregular. and it's not...
Wait, can you repeat that? Sorry.
Irregularly, irregular.
Okay, irregularly irregular.
Yeah, and it's just what they want to hear.
Yeah, no,
it's
Don't forget the ly at the end.
I know,
That's
right?
irregular.
I'm definitely going to get that wrong. But anyway.
and just take your time when you're saying it. They'll know that it's a mouthful. It's a mouthful for us all, Okay, good. And Aidan, what are you going to do next? You're in the car, so you want to think of the causes.
Yes,
Okay, so what are the causes?
So the three big causes of atrial fibrillation are thyrotoxicosis, valvular heart disease, and ischemic heart disease.
I blame that on
Yeah,
JT
yeah.
because he mentioned thyroid.
Yeah,
so
that's too much thyroid. But then there are also some other causes, including a post-operative patient, patient recovering from an infection, or electrolyte disturbances,
Like what?
like hyperkalemia, hypokalemia, perhaps.
Yeah, and same with magnesium.
Yeah.
It's mainly the hypos actually.
Right, hypo.
Mainly the hypos. Yeah.
No natremia?
No, natremia, not really. No, it'd be mainly the hypomagnesemia and hypokalemia.
How about calcium?
Can do. Again, I think you're a bit of a bunny rabbit seeker.
Okay, I'll stop.
Do you want to get through the 8-minute walkie, or do you want to stay there for 10 minutes?
It's not that the questions aren't good. It's that if that's your train of thought, if you're willing to focus on one bit, you will get dragged down that hole. When you hear atrial fibrillation, you're like, I have 3 minutes to get CAOR out, and nothing's stopping me.
Yeah.
So once you've said the causes, you just need to get on to anticoagulation.
Yeah.
If you allow me to burn down the clock, you got no marks for that.
Sure.
Even if you just blurted out a Pixivan.
Yeah.
So I'll now give you the chance. So you've identified the cause and you're looking to treat that. Now what are you going to do?
A for anticoagulants.
Don't say that to the exam. It's like anything. It's like anything though. If you have a cool mnemonic, don't just say the mnemonic and then go through it, because then they see how your brain's working.
You got to fake.
Whereas they want to see that he thought of the causes and then now he's going to the anticoagulation.
Now I'm gonna worry about I'll do a CHAD 2 VAS score, and then from there, then I will determine whether the eligibility for apixaban or warfarin.
Yeah. And why would you do one over the other?
Warfarin, you have the two cases where it's metallic heart valve or valvular heart disease.
Yeah, exactly right.
And then apixaban, it's 5 milligrams BD.
Yeah.
Unless they're the 60 kilograms, 80 age, and
less than 60 kilos,
above
over
80 and 133 creatine.
And
that's half.
If they have 2 out of 3 of those criteria, all right.
All right, yeah.
And the way to start off the anticoagulation section is, I would like to then consider anticoagulation. This would be considered using the CHADS 2 VAS score.
I got to record these statements, like these phrases.
I think you are recording. Once you say you're considering anticoagulation, you haven't cornered yourself. You're not saying I would anticoagulate, because then they jump in and say, would you? And say, I'd consider it. I would see what their CHADS 2 VAS is. I'd see what their HASBED is, as you pointed out earlier. I would identify if they have a metallic heart valve, and this would inform my choice of anticoagulant. But in general, I think NOACs are safer these days, and they are approved for the treatment of atrial fibrillation. I'll give apixaban 5 milligrams BD. Then, if they want to corner you and ask, would you always give apixaban, I'll let them. But you're already armed for that. but now you're running out of time, so now you need to get onto OR, okay? And you need to just have two statements. So rate or rhythm control. In a person with permanent atrial fibrillation who we have no intention of rhythm controlling, rate control with a beta blocker might be appropriate.
Yeah.
However, for a younger patient, I would rhythm control them. And now you've got them, they're listening, they want to know what are you coming out with next. Just say I'd calculate their CHA2-VASc score. If it was 1 or greater, I'd anticoagulate them for 3 weeks before bringing them back for DC cardioversion. If they went down the track of saying, okay, and what happens if that DC cardioversion failed? You're getting a B now, I just want to see, can you get an A?
Refer to cardiologists.
Yeah, exactly.
Oh, it is?
Right?
Oh, right.
Yeah, of course. Oh. Because the follow-up is the important bit here.
Yeah.
So you're following them up. You want to make sure, why did they have atrial fibrillation? You're referring to cardiology, but before you do that, you're getting them an echo, a transthoracic echo, and you're referring them to cardiology for cardiological assessment. And if they had persistent atrial fibrillation despite DC cardioversions,
can you explain what that is?
A DC cardioversion?
Yeah.
Yeah, direct current cardioversion. It's basically where you have to give them 3 weeks of anticoagulation, because if a clot has formed in their heart and they have atrial fibrillation, all of a sudden you shock them out of atrial fibrillation, their heart starts pumping effectively again. It'll pump that clot out and they'll have a stroke. So you need to anticoagulate them for 3 weeks, all right? And you can bring them back and you just put the pads on their chest. You synchronize the shock. And you'll give them some sedation, and you'll give them a shock, and that will knock them out of atrial fibrillation, you would hope. All right? And then, if that failed, you would again refer to cardiology, but they might consider doing an ablation. Ablations have quite a high failure rate, and it's not uncommon for people to have 2 or 3 ablations, but ultimately they can be quite successful, especially in younger people. Yeah. That's basically everything about atrial fibrillation. Certainly all the high bang for buck stuff.
Simples. I like it. So you just have to repeat exactly what Will said there in order to get 100% in your OSCE. It's simple. It's easy.
You won't have to. You actually won't have to repeat all of that. No, you'd be surprised that they'll just get the gist that you know your stuff and you'll just keep talking. Yeah. Which is why I just think that, like, if you just get through CA, or if you even said 10 or 20% of everything that I said perceived for AA, they might just say, you'd say, I'll treat the cause, valvular heart disease, ischemic heart disease, thyrotoxicosis. Say, yeah, next, okay, what else would you do? Well, I'd also, I'd anticoagulate. So they might literally just want to see that your eyes don't light up when you mention something, or when they mention something that you get afraid because you don't know the answer.
Thank you.
All right.
Yeah, thanks.
Happy?
Yeah, fantastic.
All right, good.
Thank you.
Yeah, thanks, Will. Thanks for coming in today on the 1 p.m. podcast, and we will see you next time at 1 p.m. Bye-bye.
Irregular.
Don't say irregularly, irregular.
Can you repeat that? Sorry.
Irregularly, irregular.
Okay, irregular.
Thank you so much for listening to our episode this week. To get the most out of this podcast, check out our Anki flashcards and our Notion document. For all your first principles, keep it right here at 1 p.m.